I have a question actually in general to all of you. Is anyone, has anyone data whether if you have active syphilis, whether PrEP is equally efficient, and what to expect of HCV infection? Are you monitoring HCV infection in people receiving PrEP? Because there might be a higher risk of HCV infection.
Pep, you want to answer?
No, I don't have an answer for the syphilis or the relationship. Just I would say that if you are able to detect STIs, including syphilis, by a regular STI screening, then you will be able to detect earlier STI infection, which will probably, or for sure, will impact the evolution of the syphilis. Regarding hepatitis C, yes, it's monitored in the PROUD study, for instance, and they have detected some, I don't remember, I think 6 cases, if I'm not wrong, of hep C among the PrEP users. So it has to also be monitored, of course. And not yet clear, as far as I know, whether it's an association or statistically significant, no? But yeah.
Hi, I just wanted to make a comment because 2 of the speakers said individuals taking PrEP are not really, quote, patients. And I think that really is a disservice to PrEP because firstly, it's a prescription medication. Secondly, there are toxicities and side effects that need to be monitored. And I just have a problem that if people perceive it to be something like over-the-counter, we're going to have a lot of people like Richard's case number 2 taking intermittent PrEP or taking PrEP not properly, and in that case getting failures to PrEP. And I think in order for this to be successful, we're going to need family physicians in the community to prescribe PrEP, not HIV-treating doctors. Because I agree they're not my patient yet, but we need family physicians to be prescribing them like birth control pills for females, for example. If we told women who are healthy that taking birth control pills is not a real patient, we're going to see a lot of unwanted pregnancies, a lot of cervical cancer, because people are not going to take it properly. So I just think we need to, as a group of people who are heavily invested in HIV, to take this much more seriously in the way we refer to people on PrEP. They should be treated as patients.
I'm not sure. I mean, I sympathize with the fact that it's not giving away candy, but I'm not sure that it automatically implies that you become a patient, but that's a separate discussion. You refer to family practitioners as the persons to prescribe it. I think it's actually culturally and infrastructure depending who will prescribe. I mean, in the Netherlands, we're currently discussing that what we call the sexual health clinics are going to be the places for prescription because they're much more aware of sexual health in general. So prescribing PrEP is also allowing to counsel people around their sexual health. So I think the implementation and who's going to prescribe it will really be depending on different options, in my view. But
I agree. Just in Toronto, for example, the sexual clinics do prescribe it, but otherwise it's all the HIV-treating physicians who are prescribing it. And so there's a lot of people who don't know to come and see me for PrEP because I treat HIV. I'm off their radar, whereas their primary care physician should open a dialogue with them. You're a gay man, you're a prostitute, you're an IV drug user, have you thought about PrEP, whatever. I mean, that's the only way this is going to work, is if you get people at that ground level. Once they come and see me, often it's too late.
I think that point's well taken. I'd just say that when I said they're not patients, I meant they just weren't sick. It's just in our context, we'd use that, or in my context, patient just means you're sick. So.
I would like to refer to the French guidelines on how PrEP should be prescribed and monitored. And if I remember it correctly, it's from the beginning of 2016. They want the PrEP being prescribed by a physician who has experience with HIV infections, so that this physician can identify if it happens in acute HIV infection, and if necessary, could maybe counsel the patient adequately and not prescribe a PrEP in an acute infection. Are you so sure that a family doctor or a GP would be the expert to identify an acute HIV infection?
I totally agree. In Canada, for example, we're working on guidelines now for the treatment of PrEP so that family doctors can do that, which includes screening for all STDs, hepatitis C, and HIV every 3 months. And you only get your next prescription for 3 months once you've been screened. So those are the kind of guidelines that we're trying to develop. And so any family doctor in Canada can do an HIV test. And so that's the kind of guidelines we're trying to formulate right now in Canada, is that every 3 months you get a prescription for Truvada, you come back in 3 months, you get HIV, VDRL, HCV, syphilis, gonorrhea, creatinine. And then when you pass, you get your next 3-month prescription.
I think a potential concern, but I'm not sure that that should be an absolute problem, is that if you model the cost effectiveness of PrEP, it is cost effectiveness if you prescribe it for people with a relatively high risk. The cost effectiveness goes down tremendously if you start to prescribe it for grandparents and children, right?
But
let me finish the argument. So you need a proper assessment of risk as a community before you prescribe it. Otherwise, you really start to spend money on something which is not really meaningful. If you were to leave it to the general practitioner to prescribe it, I think you stress the relationship between patient and doctor, because the patient would like to say, I get my PrEP, and the doctor then is in the position. From a community perspective, we won't prescribe. So for that reason, I think it's actually, you could argue it probably makes more sense to leave it to a sexual health clinic, because there's another type of relationship there. But that's just, we don't have to endlessly discuss it, but I think that's something to take into account.
Yeah, what I didn't say is the guidelines were also for patients or individuals who are at risk. It wasn't for the general population. So once risk is determined to be of benefit, then that's how to prescribe PrEP.
Microphone 4, we're waiting here.
This is a comment or a question for Richard. Maybe I missed it, but do you think phylogenetics could play any role for especially for that patient that you're not really sure on if it's really a matter of resistance arising after PrEP, or did you do anything with this? Did you look around and see if these viruses are related to any viruses circulating in Canada whatsoever?
No. So we did phylogenetics within the individual, his population, by doing deep sequencing. We really didn't find anything that we didn't see from the population sequencing. We didn't try, and actually, as a rule of thumb, I don't try to ever link person A to person B through phylogenetics, because I think that leads to places I don't want to go.
Richard, just staying on the resistance topic for a minute, in your first patient, I think the phenotype showed that he was 1.3-fold, had 1.3-fold increase in IC50 to tenofovir, which is low but can be relevant. And he had a 184V, but presumably makes him completely resistant to 3TC. You think that's pointing out to the effect of 3TC that was lost there, but maybe more important than we anticipated?
I mean, I'm sure that both of them are contributors. I mean, he had a bunch of TAMs, so lost some or most of the activity of the tenofovir, and most of the activity of the FTC. So there wasn't a lot left that you could expect out of the PrEP from either drug, really, I think.
It still puzzled me, because if you look at the resistance profile, if you put that in Stanford or look in literature, I think tenofovir would still be active.
I mean, it's partially active, but it's had a bite, certainly a bite taken out of it, and some of those things may well, we don't know what the source patient had. We know what the thank you, patient had. Maybe it's subtly different, right? If he had a 215Y, that would have been off the scale for tenofovir resistance.
So he had high drug levels, wasn't it? But you also had a co-medication.
I don't know the details of the co-medications. Those co-medications were mostly as needed. So I don't know what he was taking when, but he had he had reasonably high drug levels, so it probably doesn't matter what else you're taking. If you got lots of drug in you, that's probably what counts.
So,
Microphone 3.
thank you. Richard, again, drug resistance. And coming back to the phylogenetic trees too, you could do that easily anonymously, so you don't have to check back for the IDs of the patients, but see if you can identify clusters. In particular, if the drug resistance profiles you identify in 1.5 cases are quite similar with 67E and G and 69D and 181C, which is an NNRTI mutation and shouldn't be selected by tenofovir FTC combination at all. So I don't think this drug resistance profile has been selected, but transmitted in these cases. So yeah, I think this is an easy answer to provide. Don't you think so? But the other thing is the phenotype. The phenotype, Charles, there's clear data. In the past, we had clear evidence that K65R mutation is underestimated, and tenofovir resistance can be underestimated by phenotypic assays. So I would say even 1.3 is a clear hint that there is something in the drug resistance profile. Okay, so I would say there was some contribution to both drugs.
I would probably agree, but I also think that there is an additional effect of TreatTC, especially in this patient, because normally you lose the 184V in this patient, it's still the 184V, right?
Yeah. Well, we did deep sequencing. We didn't see any K65R even at 2%.
No,
we cheerfully do phylogenetic analyses on groups of patients all the time, but I won't look really just to satisfy my own curiosity to link one patient putatively link one patient to another. I'm not going to do it.
No, I understand that really I do, because that's really a hot topic to do so, and I wouldn't do it neither. But the other thing is, what we should really be careful if we have the knowledge and know that we can see appearance of drug resistance in the context of PrEP. We should do whatever we can to differentiate between the probable transmission that cannot be avoided by this kind of PrEP and the selection of new drug resistance that can be an associated risk of PrEP at all, but wasn't probably the case in the cases you presented here, because one is not the fault of the PrEP, the other would be. That's different, and so we should really try to differentiate those two completely different things.
Yeah, I just am, when it comes really right down to it, I'm not sure how we will ever differentiate it.
But the presence of 181C, there's a clear hint, right?
So when did he have a 181C? He was initially infected with a 181C, but was just that, or don't know?
Yeah, okay, but on the other hand, if there has been transmission already, proven transmission of a drug-resistant strain, it could easily be resistant to more than one drug, right?
I think the future will tell us what type of mechanism is driving this. But, so let's move on. Roger.
I have a more general question for Drs. Webb and maybe Dr. Colliold. So when people are offered in places where patients, let's say, have two options, so they can either buy PrEP on the internet or they can go to a formal place where they get some advice and global health assessment, what do they do? Where do they get PrEP? I mean, how, in other words, what proportion of our patients in an ideal scenario would be taking PrEP in an uncontrolled manner, without?
I don't think anyone should be taking PrEP without medical supervision, right? Because if they're not tested, they don't know if they're positive or negative. So the whole situation has arisen because we have not PrEP is not authorised. So the only place to get it is in a clinical trial, and the AmPrEP study recruited 500 people in 24 hours. So, there is demand, and the only reason that people are looking for doing it themselves and have been really creative and done a lot of research and found out all the legal situation is because they really want to get PrEP. You can get it from a clinic and you can get it in some countries when you've got a prescription, but you have to pay £500 a month for the drug, and you might have to pay for your renal tests and all the other tests around that. So it's not an option. At the moment, it's a luxury option for a handful of people in Western Europe. It's just not an option for most people.
Yes, I just want to ask the panel the concept of, in view of a case presentation of tailored PrEP, there are maybe situations, apart from using Truvada alone, there may be situations where you know that the patient of yours has resistant viruses, and there may be relationship issues where the partners are imbalanced in relationship, and whether or not other agents like Chinvoya or others, and a concept of funding that, not just restricted to Truvada alone. And I don't know whether France's funding is restricted to Truvada, or is it just a concept of PrEP in general?
It's actually a very interesting question. Who wants to address it? So your question is if you know that PrEP would not be your drug of choice because there is resistance in the index case. Yeah.
Truvada is not a drug of choice because you know that your patient has resistant viruses.
Yeah.
And there is an imbalance of power in the relationship, or there is a few, there is condom.
But
there are situations like that.
But that's going to be, sure, I understand, but it's going to be a relatively rare situation because it would imply that the index case is not suppressed. If you cannot suppress the index case, then it's unlikely that you'll find PrEP to protect the partner. Because if you have a drug that would protect, you would give it to the index case. You see what I mean? It's quite an artificial setup, but I think it argues. I think the one bigger problem with PrEP is, I guess, is that currently we are using PrEP drugs and treatment drugs, the same class for both indications. And theoretically and practically, that's potentially a setup for trouble. So eventually, in the future, what would be nice, we have to stimulate the companies, that we could reserve a separate class, or at least drugs with a separate resistance profile from the ones that we're going to use at least in first and second line. That would be a future scenario, which I think makes it more attractive than what we are currently doing. But still, your individual case, if somebody wants to comment, Richard?
I mean, I think it'd be a case where it would certainly make sense. I can't see that being agreed upon policy by those who make policies. They will probably just say, well, when things like that happen, you just do whatever you want. But I can actually see that is something that's gonna come up. It's not, 10% of the people that we tested in the last year had an M1A4V at some point in the previous year. So that's only the people we've tested. So maybe 2% of the people who we follow showed up in at least once in the year with an M1A4V virus. So, it's not that rare to have something that might take a bite out of the effectiveness of PrEP.
So my question is that the PrEP, in terms of funding, should that just be restricted to Truvada because there's a lot of evidence, but should be extended as a PrEP in general to perhaps Chinvoya or other things?
From a community perspective, We have been advocating that other companies look into the potential of their drugs into the PrEP as well, but to my knowledge, apart from cabotegravir, nothing has really been as promising as the Truvada. We don't know about the Maraviroc yet. That is maybe a second option which comes up. But maybe we need to combine two pills from two different classes, and it will not be as comfortable with the Truvada for other cases. And the systematic approach to look into PrEP is needed.
I think trying to convince people to fund something where there's a lot of data is hard enough, and then trying to expand beyond that, at least now, is impossible.
Pep wants to say something in Rebecca.
Yeah, regarding Maraviroc, we implemented a study. It was using an explant model. So we tried to see whether Maraviroc was protecting against HIV infection in tissues, and we didn't see any protection. We had also a control group. It was a small study, but what we gave Truvada to two of them, and there was protection, but not with Maraviroc. We published that in last year. Regarding other drugs, well, I think that there is it's been planned to implement a study with TAF. It would be a non-inferiority study, but not started yet. Has not started yet, but it's another. I think that is another study, future study.
The WHO has also had a meeting to discuss whether 3TC would be an alternative given the lower cost, and they concluded that we don't know whether it's as effective as Truvada, but it's being talked about as an option.